Hi, my name is Clinical Gladys and you're watching the video on the characteristics of non-accommodative esotropias. Okay, in this video we're discussing esotropias that are non-accommodative and either intermittent or constant. For the intermittent deviations, where we have a convergence excess deviation, the deviation or the esotropia is present at near, but the patient is straight at far. For divergence weakness, the patient is straight at near, but there is an esotropia at far. And for the basic, we have the deviation being intermittent both at near and far. We also have the cyclic esotropia, which is where we have an esotropia that occurs on a regular interval. With the constant primary deviations, they can also have a convergence excess, divergence weakness or basic pattern. But in these instances, obviously the patient has a constant deviation, but the deviation is greater at near, greater at far, or very similar between near and far. Now, the conditions I've just mentioned are generally acquired. They occur after the first 6 months of life, usually after the age of 1. However, there are conditions that can occur congenitally, so at birth, or can be considered infantile, which means that it has occurred under 6 months of age. As an example, an infantile esotropia occurs under 6 months of age. The alternative is that the patient acquires the esotropia at a later stage. So here I've added that you can have an acute onset esotropia, whereby the deviation tends to occur later at about 5 years of age or so. This is still acquired because it obviously develops after 6 months of age, but it has its own subclassification, as we'll see in a moment, because there's certain other considerations that we need to make for these patients. We'll go through this and the conditions that I've mentioned or haven't mentioned yet in a moment. So what is the cause of a non-accommodative esotropia? Well, in order for it to be classified as a non-accommodative esotropia, there has to be no accommodative reason for the deviation. So it can't be that the patient is hypermetropic. What I mean by this is that if they are hypermetropic, when you prescribe the hypermetropia, there is no change to the deviation. So the hypermetropia is not linked to the size of the deviation or the control of the deviation. The other is the ACA ratio. A high ACA ratio indicates that the patient has an accommodative esotropia. So the absence of a high ACA ratio indicates you have a non-accommodative ESO. And lastly, I've added there that the patient won't have a hypoaccommodative issue because these patients get classified as having an accommodative ET. So the causes of non-accommodative ETs relates back to anatomical and mechanical factors. Okay, let's go through each of the various types of esotropias that are non-accommodative, and I'll just highlight some of the important points and distinctions regarding these conditions. Starting with the convergence excess esotropia, what is causing this deviation to be larger at near? It can't be a high ACA ratio in this instance because otherwise they will be classified as an accommodative ET. So for these patients, the ACA ratio should be normal or low. But what you may find is a high PCA ratio. If you have a normal ACA and a high PCA ratio, that means that your patient has a non-accommodative convergence excess esotropia. If you find a normal ACA ratio and a normal PCA ratio, this means that there is high tonic convergence, but because we can't clinically measure tonic convergence, we won't be able to confirm that this is the reason. But it's understood that that's the most likely reason for why we get that convergence excess pattern in these patients. So, a patient with a convergence excess pattern that has a high ACA ratio gets classified as an accommodative convergence excess ET, but a patient with a normal ACA ratio with either a normal or high PCA ratio is considered to have a non-accommodative convergence excess ET. Now, divergence weakness esotropias are not very common. They're actually very rare. And when you see a divergence weakness pattern, you should actually suspect a sixth nerve palsy. A sixth nerve palsy means that there is a deficit of the innervation to the lateral rectus. And because the lateral rectus are utilised in the distance, when the patient looks into the distance, their esotropia will get larger at that distance. If it's not innervational, then it's likely that there is a displacement of the horizontal muscle pulley. But this, in order to confirm it, you would need to actually undertake an MRI. And finally, with the basic deviation, the size of the deviation is similar near and far, and this could be either intermittent or constant. Moving on to the cyclic esotropia, this is a deviation that occurs at regular intervals. So as an example, it might be that you have a 24-hour period where the patient has an esotropia, followed by a 24-hour period where the patient is straight, followed by a 24-hour period where the patient has an esotropia, followed by a 24-hour period where they're straight, and so on and so forth. So there is a cyclic pattern to this deviation. Generally, these become constant over time, and in the end, you end up treating them as a basic constant non-accommodative esotropia. Infantile esotropia, this condition, as I mentioned earlier, is an esotropia that occurs under 6 months of age. Because we have disruption to BSV at such an early age, what we find within infantile esotropia is that there are a number of associated clinical features. And I've mentioned here, you'll see I've indicated the patient may have what's called DVD, inferior oblique overactions, latent nystagmus, cross-fixation, and nasal temporal asymmetry. I'll take you through these in another video, but it's important to understand that an infantile esotropia has the esotropia with a number of other clinical features. Okay, the microtropia. The microtropia is a small angle strabismus. We're usually talking about a 10 diopter or less ESO deviation. And these patients, despite having a manifest strabismus, will demonstrate binocular functions. So we see here, I've given you an example of the left esotropia of 5 diopters. And what we see is the patient gives you a BSV response on Bagolini striated glasses, and they have stereoacuity using contour line. However, they fail the Lang because that requires the patient to be bifoveal. So these patients have binocular functions, but they're considered to be subnormal. Nystagmus blockage syndrome. Here we have an esotropia which is being used to block or dampen, either in part or totally, nystagmus. So essentially, adduction dampens the nystagmus. So what we'll see is a large esotropia and often a head posture. And the head posture will be such that the patient will turn their head to the side of the fixing eye. So in the example here, we've got a left esotropia. So the eye that's fixing is the right eye, and the head is turned to the right. And the reason they turn their head to the right is if you turn it in that direction, the right eye will move into an adducted position and the left eye will abduct. But because the left eye is esotropic, that will stay in. But now you'll also have an adducted right eye. So these patients look as if they're cross-eyed and then both eyes are crossed. But indeed what they're actually doing is fixing with the right eye. It's just that they've got this head turn, which is causing adduction of the right eye. Esotropia with myopia or associated with myopia, you only classify a patient with this condition if they have a high amount of myopia. So a patient with, example, -1 myopia, you don't actually indicate that this is an esotropia with myopia. We're looking at amounts of at least 6 diopters, and some of these patients will have very high myopia, such as 15 diopters of myopia. What you'll also see with these patients is they often have a vertical deviation, and this is generally considered to be caused by pulley displacement. Acute late onset esotropia or normosensorial late onset esotropia. Here we have an esotropia that is of sudden onset. Now it can occur intermittently to start off with and then become constant, but the history is such that it is acute and sudden when it develops. More often than not, it develops around the age of 4 to 5 and can develop up to about the age of 8 or so. It can also develop at a younger age. It can develop at the age of 2, 3, 4, but more commonly it's towards that 4 or 5 year age range. Now, because it is of sudden onset, generally if the child is old enough, they will complain of diplopia. Patients with other types of non-accommodative esotropias tend not to complain of double vision or sudden onset double vision. Now, the reason it's important to distinguish this strabismus from other types of non-accommodative strabismus is that this can be related to a sinister cause, and in particular a brain tumour. It has been found to be related to brainstem, cerebellum and pituitary tumours. However, it could be that the cause is unknown, or it could be a microtropia that's broken down and become a large angle esotropia. So the child once had a 5-degree eye turn, and then suddenly it's become a large angle esotropia, and they'll present to you with diplopia and that history of a sudden onset strabismus. Here is an example of where history taking is really important, and that you document as best you can the onset of the deviation. And lastly, we have the secondary residual and consecutive esotropia. So for the secondary deviation, here we have an esotropia that's developed secondarily to a defect that's obstructing binocularity, such as a cataract, such as a corneal scar, etc. Usually children are the ones who develop an esotropia secondary to a pathology. The residual esotropia is the patient who has had preoperatively an esotropia, has an operation, and post-operatively there is an esotropia remaining. You'll also hear the term used when discussing, for instance, partially accommodative esotropias. With the glasses on, you can indicate there is a residual esotropia with glasses on, because it corrects part of it, but not the esotropia completely. Okay, and finally, consecutive esotropia. Here we have a patient who used to have an exotropia, has been operated on, and subsequently, post-operatively, has had an overcorrection and now has an esotropia. Okay, that brings us to the conclusion of this video. Thank you for watching.